We'd like to welcome everyone and thank you for joining us for tonight's UMiami Health Talk. COVID-19 prompts transformative shift to outpatient joint replacement. Patients can now go home same day of surgery. I'm going to be your moderator for the evening, health journalist Ileana Bravo. Tonight's UMiami Health Talk is presented by UHealth Virtual Clinics. Our expert providers are ready to care for you, and they can do it in our facilities or virtually wherever you are. We invite you to learn more about the measures we have in place to keep you safe, as well as your appointment scheduling options by visiting umiamihealth.org. Tonight, we're going to hear from those two distinguished gentlemen on your screen, internationally known University of Miami Health System orthopedic experts, Dr. Raymond Robinson and Dr. Jaime Carvajal. Each of our expert panelists will speak on different aspects of knee and hip replacement and how COVID-19 has transformed joint replacement surgery for the benefit of you, the patient. Now, during each panelist presentation, we're going to poll the audience, and we ask for you to participate, answer those questions. It gives us a great idea of where we're going with the topic, and the answers are anonymous. And also there's going to be a question and answer session at the end of our expert providers' presentations. And if you have not submitted in advance, you have plenty of time to do so. Take a look at your Zoom screen, the feature at the bottom of your Zoom screen, that's the Q&A, the two little boxes that say Q&A, that's where you're going to enter them. We will queue them up and tee them up for our providers at the end of the presentation. So let us begin. I'm pleased to introduce our first presenter, Dr. Raymond Robinson. He's professor of clinical orthopedics and chief emeritus of the UHealth Joint Reconstruction at the University of Miami Miller School of Medicine. Dr. Robinson is an internationally known innovator in the field of joint replacements whose training includes biomedical engineering in addition to orthopedics. Dr. Robinson's presentation will provide an overview of orthopedic surgery. Dr. Robinson, take it away.
Thank you, Ileana. It's a pleasure to be here, and thank you all for participating in our webinar. I'm going to be covering kind of the basics on total hip and total knee replacement. What are they? What are they today? I find with my patients there's a lot of misinformation out there, a lot of old information that makes a difference in your care.
So that leads us to the very first poll question. We're going to kick it off quickly. And that is, have you avoided, those of you in the audience, have you avoided or delayed seeking medical care during the pandemic? In other words, has COVID-19 kept you from coming in to see a doctor, to a medical facility? It's yes or no. Have you avoided or delayed seeking medical care during the pandemic? And you have to enter it by clicking on it to see our results. So Dr. Robinson, 66%, the majority say yes, they have.
So you might be surprised that you'd probably get the same answer in the early days of COVID from the healthcare providers. We were all afraid. But at this point, I must say, I feel safer in the hospital than I do in my own home. I live in a condominium. But when we look at the things that are being done at the university, there's really no place safer than at the University of Miami. So when we start by talking about hip replacements, it's interesting to note how much hip replacements have changed over the years. Look at this original implant, 1927, that was made out of ivory. That was a problem because ivory is resorbed in the body. The first real hip replacement is the second one, 1938, and then you see this work of art in 1940. So we weren't the first ones to be concerned about finding ways to reconstruct the hip joint or the knee joint for that matter. Then came along Sir John Charnley introducing his revolutionary total hip replacement in 1963. That really was the first highly successful, widely used hip replacement. And now in today's implants, we have benefited from all that we learned from those days, and we have the hip replacement, more of what you see today. So today, the cemented hip replacement still exists. We use it in certain situations, but by and large in the United States, uncemented hip replacements have taken their place as the major implants used for hip replacement surgery. So that means that on the socket side of the hip, we use a titanium alloy cup that has a very special bubbly backing that is called a bone ingrowth surface, and bone likes to grow into this surface to give excellent fixation over a very long period of time. The ball of the hip joint is replaced with a ceramic ball most commonly now, and that ball is attached to a stem that takes advantage of the upper relatively hollow portion of the femur. And the stem has a special surface variety of options that stimulate bone to grow onto the surface of the implant. The other changes that have occurred are the kinds of bearing surfaces that are used, and this is important in many respects. There's the traditional metal ball on plastic still, but the plastic has changed. It's become what's called highly cross-linked polyethylene plastic, which is incredibly resistant to, to wear. The most common articulation is this ceramic ball against the cross-linked polyethylene plastic. Metal on metal has fallen into disfavor largely because of the concerns of metal ions. But ceramic on ceramic is another hard on hard articulation that is still alive and well, and we use it at times today. There's a tremendous amount of planning that goes into doing a hip replacement that most patients are not aware of. Patients are concerned, is my leg length going to be right? Is everything going to go okay? What kind of implant are you going to use? This all comes into the surgeon's planning. And on the right, you see a typical digital templating plan of attack for this particular patient. But don't forget, the patient needs to do some planning prior to hip replacement or knee replacement as well. You want to maximize your chances for success. So you're part of the team. You have to stop smoking. You have to lose weight if possible. You have to maintain your strength and flexibility as much as possible, recognizing that when you have a major weight-bearing joint like a hip or a knee worn out, it's like having a flat tire. You can't exercise it away, and it becomes more and more difficult as the symptoms get worse to find forms of exercise that you can do without aggravating the symptoms. Often when things get really bad, I recommend exercising in the buoyancy of water. It takes the load off of the joint. You also want to maximize your medical health, and this, of course, involves your internist, or if you don't have one, we can assign you one. And equally important is thinking ahead. You want to prepare your home. You want to anticipate the help that you'll need after you come home, especially as we switch more and more to these very rapid discharge situations. You need to think ahead. One of my patients said she made a bunch of dinners and froze them in the freezer so that she could just warm them up. You're not going to be disabled when you come home. You will be able to be independent. You don't need someone helping you out of the chair all the time. And you also want to be thinking ahead of how you're going to arrange transportation. There have been a lot of advertisements about different kinds of surgical approaches for hip replacement surgery. These ideas of doing it through 2 incisions that are 2 small incisions versus 1 incision, that is still alive, but is not as popular as it used to be. And even though there are all these incisions and approaches, including the direct anterior approach, be informed that all of these incisions have been around for more than 40 years. None of them are new. But They have their traditional longer incision versions, and they all have their so-called mini versions of the incisions. Um, and when you look at randomized controlled blinded studies, what you find is there really isn't a whole lot of difference comparing all of the modern types of approaches into the hip. A lot has changed with hip replacement surgery and knee replacement surgery, and it's all for the better. Surgeries typically now take about an hour to do. If your family's waiting, it doesn't seem like an hour because, of course, they don't know all the time before the operation actually started and afterwards. There are no stitches to take out anymore. They're all resorbable sutures now, unless it's a very unusual situation. There's no dressing to change. You receive a watertight dressing in the operating room that stays on for 7 days. And by the time you take it off, the wound typically is dry. You don't need to keep putting dressings on as we used to. And since it's waterproof, you can take a shower right away as soon as you're safe standing in the wet environment of the shower. Very rapid pain relieving with hip replacement. Knee replacement, a little more painful because you keep having to bend it to work with the physical therapist. But with hip replacement, immediately you have lost the pain that was coming from the bone grinding on bone in your hip. It's not unusual when I do rounds, if I am in the morning, for the patient to tell me that, well, yeah, I know it. I know you were in there. It hurts. But compared to the pain I've been putting up with for the last year, this is nothing. Rapid mobilization has made a huge difference in the recovery of patients. You can full weight bear right away, and as has been indicated by the title of this whole conference, you can go home the same day, next day, or 2 to 3 days. It all depends on how you're doing and what your situation was. We'll cover that in just a few moments. What do I look out for after the surgery? This is an operation. There can be things that can go wrong. Well, we're concerned about blood clots. That's one of the reasons you're up walking immediately after surgery. You have intermittent compression stockings, keeping the blood moving in your legs even during the surgery. You typically are given aspirin as a mild anticoagulant, but every patient is different. A lot of patients are more susceptible to blood clots, and in those cases, we use other medications to protect you against blood clots. Infection, we're always concerned with any operation, particularly joint replacements, but fortunately, the infection rate typically for a hip replacement is 0.3%, for a knee replacement in my practice is 0.8%. So that's pretty rare. Fractures can be a complication. Please don't fall. That sounds silly and obvious, but the thing is, when you do these operations, even though we don't cut any of the major muscles with any of the surgical approaches, they don't like being pulled aside. I like to say they sometimes go on strike. So you get up out of bed and you want to walk a couple steps to the bathroom, and you think your leg's going to hold you, and you don't take your walker along in the very beginning, and the leg bends unexpectedly, especially with a knee replacement. You can find yourself on the floor, and fractures can occur. So pay attention to the precautions that you were taught. Dislocation is a possibility, but now that we have the new plastics, we can use larger ball with the hip replacement. So dislocation rates have gone down now to about 0.4%, regardless of the surgical approach. Changes in leg length can be real, can be not so real. In other words, before the surgery, as your hip wore out, the leg is gradually getting shorter and shorter, and then someone like me comes along and puts it back to normal. It feels too long at times for a while because you're still tilting your pelvis down. Implants can loosen over time. Again, with these implants these days, very rare. And the sciatic nerve is right behind the hip joint, and the There are nerves, of course, in the front as well, regardless of which approach you go through. The surgeon, of course, has to be very careful. So when do I go home? I like my patients to think in terms of going up a bunch of steps. The ability to go home is very practical. Obviously, we want to make sure your health is good, but the practical nature, again, comes back to the patient. You want to reach a point where you can safely get in and out of bed by yourself. I always tell my patients when you're working with the therapist or even early on, make sure you tell them which side of the bed you get out of at home, so you're practicing. How high or low is your bed at home? Reproduce that with the therapist as you practice. How far is it to get to the bathroom and back? One of my patients said, how far is it to get to the refrigerator and back is a better question. That would be me. Do you have stairs at home? How about getting in and out of car? We're really blessed to have this unit on the right that you can see the therapists have the ability to take our patients down the hall and practice all of the things in the kitchen, even getting in and out of a car. Here's a happy driver there. So all of this is a very practical way of determining when it's okay for you to go home. And if that's the same day as surgery, so be it. What about knee replacement? There's a lot of misconception about knee replacements in my patient population. Here's this fascinating, intricate hinged implant made of ivory back in 1891. Well, even in the 60s, the knee replacement was often a total knee replacement, replacing the whole joint with a hinge. And a lot of patients still feel that that's the way knee replacement is, when in actuality, in 1970, knee replacements designs began to change because these large hinged implants had a high incidence of mechanical loosening and failure, although they worked well in the beginning. I did this history of the evolution of total knee replacements, and this slide is interesting just to show you at 1970 to 1980, there was an explosion of fascinating knee designs, some of which continued down the road to their modern versions. Others disappeared for various reasons. But just give you an idea, there should be no surprise there's so many implants on the market today from that start. Today, knee replacements are more of a resurfacing operation. Here's a diagram showing how the surgeon literally shaves off the worn out end of the thigh bone and resurfaces it with an artificial metal surface. This is about 8 millimeters thick, shaves off the worn out top of the shin bone, resurfaces that with an artificial plastic surface, often with a metal backing and a post. And even the kneecap undersurface at times is resurfaced with a plastic button. All of this is put in, and in doing so, the deformity of the leg, the bow-leggedness, the knock-kneedness is corrected. And the implant relies on the same natural ligaments, the same muscles and tendons that work across the natural knee, continue to work across the artificial knee. Sometimes, instead of resurfacing all three compartments, parts of the joint, you may just want to address one side. So if the arthritis or worn out or post-traumatic changes are only in one compartment, these are called unicompartmental knees, and those are very successful as well. Just like hip replacements, there are cemented and uncemented versions of knee replacements. In knee replacements, the cemented types of implants still dominate the field. You're still going to have to convince me that going to uncemented is an advantage. Well, how do I know when it's time to have a knee or a hip replacement? This is a diagram imagining the patient now normal. And even when you're normal, you have good days and bad days. But let's say your knee is beginning to bother you, and again, you have good days and bad days. But because of it, you begin to modify your activities. You try to lose some weight. But as the symptoms get worse, you start coming to the doctor and maybe addressing the problem with non-surgical modalities, injections, medications, modification of activities, physical therapy. Then maybe on a bad day, you even pull out a trekking pole to walk with. But we all have a threshold of acceptability. And having been a patient myself, I know that you don't know where that is until you reach it. But you'll know, because all of a sudden you'll say to yourself, my gosh, I can't even do this anymore because of this knee or this hip. And that's kind of the threshold where the symptoms determine the treatment, which in the vast majority of patients is the case. Can you wait too long to do a knee replacement? The answer is yes. Let's say you are the sole caregiver for your elderly mother or father, and because of that, even though your symptoms have reached a point where you want to go ahead, you can't. We look for a couple things. One is the continued atrophy or wasting of muscles. You can reach a point where the amount of atrophy is only partially reversible with a joint replacement. Also, we look for warning signs on X-ray. If a patient has a more aggressive loss of bone stock than this, you can get to the point where you have to change from straightforward implants to what we call modular implants that have to fill defects like this, and sometimes they add a stem to the implant because of that. So it changes the operation from a simple straightforward knee replacement into one that's more complex. So one of our jobs as we look at your x-rays and share them with you, as in this patient where it's worn out on this side, but they're beginning to stretch the normal side ligament, we want to guard you against the, we don't want to burn any bridges, let's put it that way. One of the questions commonly asked is how long do they last? Well, we have good information on that with knee replacements, and of course this is design specific, but here's a study from a friend of mine that looked at patients that had their knee replacements at 55 years of age or younger. And basically at 30 years, there's a 92% survival of those patients still living. This is very good news. We don't know, we can't promise an individual patient that their implant's going to last that long. But basically, once you reach the age of about 53, looking at actuarial tables, we begin to get confident that this should last the rest of your life. Beware that not all new ideas are advances. And one of the most important aspects of research that I'm involved in is clinical research, because new ideas come along and they need to be clinically evaluated to determine whether they're really improvements or not. So our research is focused on trying to get the best results, the least risk, and of course, cost effectiveness is also an issue. Advanced technology is here, it's here to stay. I personally do all my knees with computer navigation. The introduction of robots, which have been around for decades now, becoming more and more practical. I don't have any question that that all of us are going to be moving ahead in that direction. So success is a team effort. Our job is to teach you what's happening and why to your knee or your hip in this case. What are your choices of care? When is it time to consider surgical intervention? And what is best for you? Your job is to be honest with yourself about the magnitude of the symptoms you're putting up with and the impact that they're having on your life. Never be afraid to ask questions, even ones that you may feel uncomfortable asking, like, how many cases have you done, doctor? In your hands, what are the chances of this happening or that happening? I thank you very much. Here's the hospital that I've been a patient in, and I must say, having been here now 11 years, um, it's become a wonderful place. Thank you.
Thank you. Thank you, Dr. Robinson. Excellent. And I remind you all, since we have such a large number of participants, and you may want to enter your questions with the Q&A feature at the bottom of your Zoom screen there. There we go. We're changing things around a little. So enter them now because the Q&A session is coming up soon. But first, it's my pleasure to introduce Dr. Jaime Carvajal, Assistant Professor of Orthopedics at the University of Miami Miller School of Medicine, whose clinical focus is on joint replacement and reconstruction. Dr. Carvajal will describe the advances made in joint replacement as a direct result of the pandemic. Dr. Carvajal, you're up.
Thank you very much, Eliana. I do appreciate this opportunity to be able to reach you guys through Zoom and through this technology to tell you what we have done, what we have changed due to COVID, and the new innovations we had to come up with in order to adapt to these new challenging times. So basically, University of Miami and our group is considered one of the high volume surgical teams in South Florida, performing about 20 to 30 joint replacements per week, and obviously keeping the patients in the hospital for a day on average. And we were doing this and with very successful outcomes until March, when the governor decided to put on hold elective surgeries.
There we go.
I'm sorry?
There you go.
So we were placed on hold for elective surgeries, but we decided to start innovating. We were not able to see patients in clinic. We did not have the opportunity to follow the patients or see new patients with joint pains and joint problems. So we decided to create and grow the telemedicine system. And UHealth has been very eager in terms of expanding this type of system to reach the patients. So we were doing those type of telehealth visits before COVID, but only in very specific patients or international patients. But now we have expanded these capabilities to most of our patients for follow-ups or patients that require our attention immediately. So a lot of technology involved. We're able to get these patients' x-rays uploaded to the system so we could assess, the x-rays, the symptoms, and any treatments that we could, advise the patients to do while we were on hold. Now, we started back on elective surgeries in May. So we had about 2 months to assess the risks, to improve our bio-safety protocols and in the hospitals, and make sure that we could provide the patients a safe environment to proceed with evaluations in the clinic, as well as to proceed with elective surgeries such as hip or knee replacement. So with the hospital and with the health authorities, the biosafety protocols were put in place. And that includes having patients screened at the entrance of the hospital, having patients with social distancing, giving personal protective equipment for all the patients, and patients being admitted to the hospital for elective surgeries will all have COVID testing prior to surgery to make sure that there were COVID-free areas in the hospital. All of us as personal staff, medical staff, were keep using personal protective equipment at all times. And the idea is to assure the patients that while they're in the hospital, while they're having taken care of for us, they will be in a safe environment with a low risk of having an infection. So the other thing is the patients, the idea was to improve their pathway after surgery to get a better and faster recovery. So the time spent in the hospital was decreased. And I think we have been doing a very good job trying to improve that recovery, make it faster, and go into that transition of outpatient joint replacement, which I'll be talking now. I know Ileana has a poll question for the audience.
Yes, we do. And here it is. Would you be interested in same-day discharge for a joint replacement surgery? So all of you out in the audience, please answer yes or no if you would be interested in same-day discharge for a joint replacement surgery. This gives us an idea of kind of the profile of where people are coming from, Dr. Carvajal. I'm sure that it's probably going to be overwhelming that I would imagine people do want to go home, especially right now. Okay, 72% say yes, they would be interested. So as we expected, I think.
Yes. So I think we're all on the same page in terms of everyone is worried about COVID. They want to make sure they have a safe environment, and we have been at home most of the time, and we want to be at home, which is our safe kind of like bubble. That's where we want to be. So now patients are interested in going in, getting the replacement done because the joints are hurting a lot and they just want to get rid of the pain, but then go home on a safely manner with the pain well controlled after surgery and make sure that they can recover at home, even in a more comfortable and controlled environment. So the new things that we have done with a joint replacement surgery to accomplish that are basically paying attention to details. So we divided the entire process in three steps. The first step is the preoperative preparation. So before the surgery, we prepare the patient. We give them a class to make sure that they are fully familiarized with the process of surgery, with the process of recovery. We have physical therapists working on with them and teaching them how to walk with a walker and what are the things that they need to do or be careful about after surgery when they go home. We have a social worker trying to get everything arranged, including prescriptions and everything ready. So whenever the discharge happens, they have everything available and at hand so they can go home without any problems. So information is key. Also giving them a home exercise protocol so they can work on some pre-rehabilitation exercises. So whenever they get to the surgery, the muscles are in good shape and they can recover faster. The second step is the intraoperative process, which is when the patient comes to the hospital. So basically it's standardizing the whole process, getting the entire team in the same page, knowing what step the patient is going through and exactly the same step all the time. So it's providing a patient with a reliable system that can allow them to have everything perform efficiently and in a timely manner so they can go home the same day. So the other details that we have been paying attention to is making sure that the patient gets adequate fluid, IV fluids when they're doing surgery so they don't get dehydrated, the blood pressure doesn't drop, or they don't get dizzy after surgery. Make sure that the medications that they received for surgery are not very heavy in terms of opioids, so they're not dizzy or very groggy after surgery. We're using a medication that is called tranexamic acid, which allows for a better clotting system. So there's a very low chance of requiring a transfusion after a hip or a knee replacement. And having an anesthesia team that is involved in pain control right after, I think is key. One of the main fears of the patients about discharge so early is the pain control after surgery. They want to make sure that the pain is well controlled when they go home. They don't want to go home and then feel that there was nobody around. So, and that's the third step. The third step is when we come up and we assure the patient that we're there for them. The idea for them is to come back on day one for physical therapy, because we want to start them, as Dr. Robinson mentioned, the early mobilization, start working to get them functionally back in an early manner. So the idea is to bring them back to physical therapy early after, and also creating channels for communication. I believe that communicating with patients through email or through our office, I think is key, because I think patients always have questions or they have concerns, and it's better to have full connection with the patient and make sure that they can reach us and make sure that we can cover every question that they have. So pain control and full communication after surgery is key. We have done outpatient joints and have not have any problems. The patient satisfaction is very high, and they just really like the experience of having everything working perfectly and in a reliable system that can get them up and moving in a quick manner. And I think joint replacement, as Dr. Robinson said, has improved over the last 20 years, and are those little details that we have been kind of like fine-tuning that make joint replacement process and recovery process better, easier, and the patients get better satisfaction and better and faster recovery. So I think it's a perfect timing for doing outpatient joints, especially with the pandemic. But I think it's here to stay. I think the patients and the public in general will be hearing more and more about outpatient joints in the near future, as well as telehealth. I think those two things are here to stay, and will be providing those as convenient to the patients.
Thank you, Dr. Carvajal. And I think good timing, because we have about 25 minutes and we have a flurry of questions, of course, from a very interested public and audience. So let's begin the Q&A session right now. And a lot of the concerns we're hearing from patients is sort of the opposite side of the coin of going home right away, and that is fear. Is it too soon? Am I ready to come home? How do I prepare my home post-surgery? Both of you, please weigh in on this.
I think one of the things I've noticed with the coronavirus is it used to be that the patient and their family were most resistant to going home sooner than later. Now there are kind of two different types of patients. Those that want to go home right away, they're very motivated, and those that are still wondering, are they going to kick me out of the hospital? That's why I prefer to think of the discharge, as my slide shows, as a sequence of steps, and once you accomplish them, one of my patients with good humor said, I get it, doc, as soon as I can make it to the front door, I'm out of here. Nobody's kicking you out of the hospital. It's an option that is now available for patients to recover. The recovery is not faster just because you got out of the hospital. But we now have the opportunity, as Dr. Carvajal explained, to do these rapid discharges.
Correct.
What's your opinion on that, Dr. Carvajal? I mean, because do people need some special equipment at home, or how to deal with pain management once they're out of the hospital?
That's a great question, and that's, as I said, one of the main fears of patients is pain control after surgery. So one of the things that we have provided for patients to have a faster recovery and going home is having a anesthesiologist working on a regional pain management. And what that means is we have come up with different type of blocks, especially for knee replacements. As Dr. Robinson said, those are the ones that are a little bit more painful than hip replacements. And they provide, and we have a team of regional pain management physicians that could provide the patients with a nerve block around that area of the knee to make sure that the first few hours or even days after surgery, the pain is at a minimum. Obviously, we do provide the patients with prescriptions for pain control, as we would do in the hospital with medications for pain. But I think the key now is the nerve blocks, providing pain relief on the patients. For the hip patients, I don't feel that they require any type of nerve blocks, because I feel, as Dr. Robinson said as well, that the pain from a hip replacement is not as bad, is pretty well controlled with oral medications, and that's what we send the patients to. We do have capabilities of managing or changing medications for pain if necessary when the patients go home. But with the protocols that we have come up with, I think the patient pain is pretty well controlled after they go home. Now, in terms of what they need to have at home, I don't think there's a lot of changes to be made, and that's a very good question. Always they're concerned about any changes in the house or anything that they have to do, and basically it's more of a common sense, trying to get rid of things that can be an obstacle, because obviously they have, you know, limited mobility and they have to walk with a walker. So obviously everything that has, you know, it's blocking your way, it increases your risk of falling. So you don't want to have any obstacles in your house. We do provide the patients with a walker and also with a commode to make things easier and to allow them to not having to move around at home too much. But otherwise, I think it's pretty much just keeping everything simple, not working around a lot of obstacles, and making sure that they have those equipments ready for discharge.
So the other fear point is anesthesia. So from what I'm hearing with the spinal block and nerve block, is general anesthesia now a thing of the past for hip and knee replacement?
It's not a thing of the past, but in my 40 years of doing joint replacements, spinal anesthesia, I've been in institutions that have favored spinal anesthesia. General anesthesia is unnecessary unless the patient has had a lumbar spine fusion in the past, is on blood thinning medications even during the surgery to some extent. There's some situations where the anesthesiologist will wisely shy away from it. The other thing to understand is just because you have a spinal anesthesia doesn't mean you're wide awake. Some patients are afraid to have spinal. You're given a sedative, it lets you snooze, but you're breathing on your own. Statistically, it's a little bit safer, a lower risk of blood clots in veins. So we prefer spinal anesthesia, but general is still an option.
All right, let me kick up these two questions since we have so many to get to. Is first one, does the knee return to the shape that it was in pre-arthritis? And do doctors use staples for knee replacement?
The knee in terms of alignment goes back to a natural alignment. When we have arthritis and you develop arthritis in the joint, you have a joint space collapse, and that obviously involves a deformity of the limb. And we see the patients coming to the clinic with a bow leg or with a knock knee. We do, after surgery with the replacement, make the limb alignment back to normal. I do have to say that some patients can have swelling around it and scar tissue that can make, you know, the knee look cosmetically not completely normal, but in terms of alignment, it's a completely normal alignment. The second question was, I'm sorry?
Do doctors now use staples for knee replacement?
No. So we don't. I think, you know, cosmetically, staples can leave like holes and tracks on the scar. We do inside the skin type of closure, and then use a skin glue to make it heal nicely and small. So no staples.
I would say never about the staples. There are patients whose skin is so delicate and so thin that you really have a hard time doing I usually describe as the plastic surgical closure, which is our norm. Patients don't realize that it's not just the joint that suffers from the arthritis, it's also the soft tissue around the joint. Sometimes I regret the term total knee replacement because it gives the patient the impression that, oh, I'm going to get this operation, I'm going to be totally back to normal. Sometimes we can't do that, especially in post-traumatic arthritis. So it's important to keep the patient's expectations in line.
Yeah, and so along those lines, let's talk about this question. How risky is it to have a knee replacement on a leg that has had a hip replacement? Because now we live in the world of everybody with new bionic limbs. So knee replacement on same leg for hip replacement, risky, not advisable?
I have once done both a hip replacement and a knee replacement at the same time on a patient. I wouldn't recommend that. We frequently do bilateral total knee replacements and bilateral total hip replacements at one surgery. It is not an issue to have a knee replacement and a hip replacement, maybe not simultaneously, but at different times in their life on the same limb.
Dr. Carvajal, weigh in on that?
Correct. There's no increased risk of complications if you had a previous hip replacement and now you're coming for a knee replacement. There would not be any additional risks, I should say.
All right, this patient is very ambitious and wants to know how long after a hip replacement can he or she drive their car. I'm planning on traveling by car to Miami from my home, 270 miles distance. When can I drive myself home? I want to meet this person.
I mean, you're on.
Yes, so actually there's one study published by one of our team members, Dr. Hernandez, on how fast patients can drive after a joint replacement. Before, we had the idea that they had to wait 6 weeks, 8 weeks, or a long period of time because they didn't have a quick braking reaction time. It's been known now that reaction time recovers faster than what we expected. And obviously, it will depend also if it is the right side or the left side because of that, because of the braking reaction time. But usually, we're talking about 2 to 3 weeks for right side and probably sooner than that for left replacements.
But I would add, another way to answer that is how long is it safe for a patient to go home and sit in a chair for hours and hours? Not good. You're worried about blood clots in veins possibilities. So it's one thing to get in your car and drive to the grocery store. It's quite another to do a long distance drive. Now, you can be the passenger in the back seat with your legs up elevated. Elevation is the most important thing in pain control because it controls the swelling along with some ice. But driving for that real long period of time, somebody else should do that.
Here's a question that brings about all of these other non-mainstream methods. And this person wants to know about abdominal fat transplant for knee joint surgery for osteoarthritis. We've also heard of the plasma-rich PRP and stem cell and all that. So can you all talk about some of these other methods? I mean,
yes. So basically, there's a lot of alternatives for knee or hip osteoarthritis out there. The Orthopedic Association, the American Academy of Orthopedic Surgeons, come up with guidelines for treatment of osteoarthritis. And basically the way they do it is by consensus and looking what the research data shows and medical based evidence. There's no, they're not considered like a treatment for osteoarthritis right now because there's still not proof that they actually do anything to the joint space or regenerating cartilage or giving your space back. So I would be very careful with the approach you have to these new alternatives and new technologies because at this point, there's no proof that they will do basically what they're meant to do. We do, and we go by the guidelines, by the protocols on treatment of osteoarthritis, and they're very concise in saying, physical therapy, oral anti-inflammatories, weight loss, activity modifications, and maybe intra-articular injections, but not particularly of stem cells, plasma, or these type of therapies.
There's no holy grail. If there was, I'd be waiting in line. There are a lot of people making a lot of money out of doing these different types of approaches. But we still, despite all of our efforts, do not have the biologic approach that we'd like to have. Articular cartilage turns out to be a very difficult tissue to regenerate. And even if you could regenerate it, if you have a worn out knee that's bow-legged, you're going to wear away even healthy cartilage very quickly.
Yeah. I think the question again, you both alluded to the fact that people have a a threshold of when they should consider during the surgery. And this participant asks about pain. Is pain the factor? Perhaps you'd both like to reiterate what should be the points in which a patient says, that's it, I now have to consider surgery.
I would say the patient needs to answer that question because different patients react in different ways to pain. Some people have big, high pain thresholds. Some people have the opposite. The question is, how much is the pain interfering with your life and the activities that you have to do, not want to do, have to do to be happy?
I agree 100%. I think pain, it's a perception, and every patient is different. I have seen patients with normal x-rays and severe pain, and I've also seen patients with really bad x-rays and no pain. So what I tell the patients is pain is actually basically what we treat with a replacement. I mean, if you do have, we can treat other things like malalignment and other problems with the joint, but the main focus of the treatment is to get rid of the pain and allow you to get back to your function and get back to your activities. So if pain is limiting you and you have tried conservative management, it hasn't helped, and you're still struggling to go doing the activities that you need to do or you want to do, I think you're a reasonable candidate for a joint replacement.
Also, be aware that the pain isn't necessarily coming from the knee. So that you can have referred pain from the back, referred pain from the hip. You can have pain from the structures that are working the knee, the tendons, the muscles. Sometimes one can even do a diagnostic Novocaine injection into the joint to see, well, does it make any difference? And if the patient says no, not even for 10 minutes, like at the dentist numbing, well, you're barking up the wrong tree.
In your presentation, Dr. Robinson, which is a fascinating historical perspective on how far we've come in prosthesis from the old ivory ones to where we are now, it begs the question of, since patients are now younger and the spectrum really goes, I guess, from patients in their 40s up to their 70s or maybe even older, how long really do these prostheses last? I've heard everything from 10 to 15 years up to what you were saying, like 20 years.
Or 30 is what I said. Another way to look at the same question is, how active can I be with my knee replacement without wearing it out over time? And that's been a moving answer, and gratefully it's been getting more and more distant. I no longer really limit my patients' activities with, say, a knee replacement. I have several patients running marathons. The thing is, I want them to understand from a mechanical standpoint, no matter how good the artificial materials are, the day you put them in is the day it begins wearing out. And yeah, they're really good materials and they hold up very well, but be aware when you simply walk, every step you take, you put 5 times body weight across your knee joint. When you start running, it's 10 times body weight every heel strike. If you play vigorous basketball on a hard surface jumping, it's 20 to 24 times body weight load. Well, keep that in mind when you're choosing something you dearly love to do versus the dilemma of, well, I want this knee to last as long as possible.
Dr. Carvajal, yes?
Yes, no, I agree 100%. And I like to have that conversation with the patients always, because I think having realistic expectations on, how long the knee replacement or the hip replacement going to last, and what are the things that you should or should not be doing after surgery, I think it's very important, because that definitely is a key for good outcomes. And as Dr. Robinson said, it depends on how active you are and what you expect from that knee replacement or that hip replacement. But if you take care of the knee replacement or hip replacement and avoid really high impact activities, I think the technology, it's out there, and the implants are providing with long lasting implants at this point. And I feel good at proceeding with surgery in patients that are kind of like in the younger age, as Dr. Robinson said, within 50 years.
Another side of that same coin is losing weight. When I say 5 times body weight, I like to say to the patient, if you and I lose 10 pounds each, we're taking 50 pounds of a load off our joint.
Yeah. Is there such a thing as having a hip or a knee replacement, or the prosthesis being rejected by the body? Is that a complication?
No. The materials that we use today have been around for a very long time. Even allergic reactions to implant material is disputed. I'm not a believer in that. That's never been proven. What has been shown, though, is you can have an extremely low-grade infection that is misinterpreted as I'm rejecting this implant. And you may even have a situation where you can't prove it. You do aspirations, you send the fluid off to the lab, but there's some organisms, one of them is called acne, that is notorious for causing that kind of infection.
Both of you, if you would, please talk to patients again about whether this therapy after surgery, post-surgery, can be done in their home. We're living in a virtual COVID world, right? From my Zoom Pilates and yoga classes to anything like this can be done at home now, because that's of concern to patients right now.
Jaime?
Yes, so I do think, with these innovations, as I mentioned, and this new technology, now with everyone being very familiarized with Zoom and the telehealth and teleconferences, I think it's appropriate. I think the physical therapists at UM have been doing a great job working on telephysical therapy and increasing the capabilities of working with patients in long distance. And I think it can be done. And basically the main thing is to have those patients followed through the first few weeks after surgery, making sure that they're doing the home exercises, making sure that they're following the instructions given, and make sure that they're progressing well. So I think it's not only the physical therapy as it is, even though I think it's a great physical therapy, it's great quality. I think the main thing is to make sure that they follow the instructions and that we follow their progress, making sure that they are actually, going through the milestones that we expect them to be on a particular day after the recovery.
Yeah, the physical therapy after a knee replacement or a hip replacement is not rocket science. It's pretty common sense. And yes, that could be done at home. The problem is there are some patients who have a bigger challenge than others. So you can be someone who's double jointed and they come back at 6 weeks, they're already bending their knee 135 degrees when the typical patient would be bending about maybe 110 or even less, 90. But because of the nature of the collagen they were born with, they were probably really great at sprinting and jumping when they were young as compared to the flexible person who was better at long distance running. So the biology is part of this. The other thing is you can have a patient who hasn't bent their knee past 60 degrees for the last 6 years. Well, you can do the world's perfect knee replacement, but they're not going to get the home run result because their muscles and tendons haven't been stretched for so long. I would definitely want that person in the hands of a good therapist because I'd want to get to the end of their recovery and not look back and think, oh boy, if only we had done this or if only we had done that. So straightforward, well-motivated patients, maybe I would add who don't get keloids when you make an incision or have a laceration. Those are a whole different group.
And I do want to add that as of now, there's both available options, both options available. If you want to go with physical therapy, that's an option. But if you want to go in person to the therapy department, that's available as well. Going with COVID precautions within those departments as well.
Thank you both of our expert presenters for a wonderful presentation and discussion tonight, which was interactive. And unfortunately, we've come to an end, but I think that we all learned a lot. And I think that the take-home message after having any kind of joint replacement it's only the beginning. It's now what the patient does to make life better. You guys are magicians, but you can't do it all. The patient has to do their part. So thank you for being here this evening. Thank you to all of our participants. The University of Miami Health System appreciates all of you being here. We ask you to visit umiamihealth.org to learn more about the orthopedic services and make a virtual or an in-person appointment with one of our experts. And please complete the survey at the end of this talk so we can learn more about what you want to hear about in the future. Thank you all. Have a safe night. Stay safe. Be well. Good night.
Thanks so much.
Thank you.